Good afternoon. It's great to be here. Thank you for inviting me here. I can tell you that one of the things always has been in my career, things tend to come back full circle. We were just kidding about whether it's the job to be, it's one of those tough jobs. And I said, somehow I'm attracted to it. The last few jobs, I kind of feel like, okay, this is a good decision. But the reason it is for me is when I started out my career, after graduating medical school, one of the first things I did is in India, in Delhi, which is a city of 25 million people, just a city, 25 million people, now it's a state. But for the first time, we had a health secretary who had to be a physician. Think about, you've got a government now. And we went to him and said, we have a big problem with polio, what can we do about it? So in August of 1994, we actually launched the first pulse polio campaign in the country, in the city of Delhi. And in one day, all the doctors and nurses in the public sector took off and did nothing other than emergency, but vaccinate children. And we vaccinated 2.5 million kids in one day. So through that process, over next years and years and years, in about 20 years, it was eradicated from a country of 1.3 billion. That's the kind of thing that I think is exciting to do. So somehow I get attracted to these challenges, and that's what I ended up in West Virginia. And over the last several years, having served two governors, I started to think, where am I spending a lot of my time in things that we're doing? We were addressing a lot of things. And it tended to be in obviously opioids, tobacco, basically addictions. And then I thought, where am I within that spending most of my time? It tended to be on moms and babies. So that was a natural progression, because that's where really the future is. But on the other hand, that's where you can get most outcomes as well. So with that, I can tell you, I'm really excited to be joining and working at March Times, especially because this is a focus on all health of all moms and babies. And I want to talk about a little bit here. My esteemed colleagues have mentioned all, this morning about the social determinants. And if you think about it, 100 years ago in this country, the average life expectancy was, somewhere about 50 years of age. If you were born the turn of the last century, you were expected to live about 50 years, men, women, average. At the turn of the last century, you were expected to live about 80 years. And I say that especially in context that we have now 3 consecutive years where the life expectancy is expected to go down. So, what do you think causes 30 years of incline in life expectancy over a 100 years period in this country? Anybody? Mortality. What else? Vaccinations. Antibiotics. Maternal mortality. Transfusion. All right. So when people actually went and looked at this stuff, people have actually studied this. What they found was that 25 of that 30 years was because of public health interventions. They had to do with sanitation, clean water, vaccinations, immunization. They had almost nothing to do with healthcare. Almost nothing. It wasn't the laser, it wasn't the antibiotic, it wasn't the new stuff. It was actually that, seatbelt laws, those kinds of things. So I bring that up because 100 years ago, people were dying of, in this country, of pneumonias and tuberculosis and gastrointestinal infections. All those things, communicable diseases, right? And today, the biggest drivers are chronic diseases and addictions. So if you think about it, if you want to put obesity in that category as well, then it's all pretty much. So the most expensive things to talk about, the biggest budget buster, and the driver for Medicare, Medicaid, which is the biggest budget driver for the federal government, state governments, is actually a burden of chronic diseases. And if you add the drugs to it, that's the problem. And behind that comes all these addictions. So substance use, mental conditions, mental disorders, whether it's opioids, whatever, pick your flavor of the drug, or the year, or the month, smoking, tobacco, and obesity. Those are all of those causes, whether it's diabetes, hypertension, cardiovascular stroke, cancers. Those are the three buckets: tobacco, obesity, and substance. And I say that because here we are, these are all lifestyle issues, right? And we're trying to fix the problems of the 21st century with the tools of the 20th century. And that's one of the biggest issues I want you to bring your attention to. What we know from science is only about 10 to 20% maybe of your health is determined by what happens in the four walls of the doctor's office or the hospital. 90% of your health is actually dictated by the communities that we live in, right? Where we live, where we're born, where we play, where we worship, where we go to work, all those areas. So one of the paradigm shifts that's happening in front of us is we have to go to where people are, the communities, and that's where the changes will happen. So I say that because some of the examples I've set here actually speak to that and how far I think Virginia is in that. So I'm going to talk about Virginia's successes today, and then we're going to talk about some of the priority issues mentioned by Dr. Dudley, speak about all the priorities, and then looking ahead, where can we make an impact? So the biggest thing that happened, I think, well, I missed the attending the governor coming here, but I think Governor Rahul mentioned, is the Medicaid expansion. I worked very much grassroots in West Virginia to become one of the first states to expand Medicaid. But I can tell you some of the experiences from that expansion. In addition to putting 150,000 people in West Virginia into Medicaid, and you expect about 400,000 people to come into Medicaid rolls. One of the things we found was actually there was more prescribing opioids. So some people across the country with particular viewpoints said, well, there's the problem. You don't give people Medicaid because if folks get Medicaid, then they will abuse opioids more, right? That wasn't the case, but you may be exposed to that kind of criticism as well. What really happens is, what we found in experience, is people who will get into Medicaid will have a lot of chronic pain conditions. So we saw an enrollment of a lot of rheumatoid arthritis and osteoarthritis, a lot of those pain conditions for which they needed some type of treatment. And at that time, I'll show some data how states are prescribing horrible rates of prescriptions for opioids. And so the worst rates became overdoses and deaths. So that's one of the consequences we have to be careful about. But overall, that's one of the good things. I mean, access to care, expansion is so critical to getting good outcomes. I think what you're doing with the neonatal absence syndrome UI project is amazing. I think that's one of the reasons that I want to talk about a little bit about this today, in addition to my other colleagues. Antibiotic stewardship, of course, I want to touch upon today, but this is a very important issue, as well as the safety bundles of pain, as well as the maternal use of opioids and 17P. I also think the group prenatal care is critical, and the group prenatal education, I think it's critical. I'll talk about some of the work that Fontaine is doing across the country on that. And I think having been recognized as being a leader for Virginia is critical. And I'll talk about where some of those opportunities may exist for you in terms of moving forward. So I want to talk about a little bit about priorities for March times. Prematurity. As you all know, that each year March times puts out the premature birth report card. Clearly, you can see where we say in West Virginia, thank God for Mississippi. But you can clearly see that we have, states which are anywhere from red, which are F states, to D states in yellow. And then obviously the goal is to reach about 8% prematurity rate, which we're clearly not near by 2020. And it's tough. I mean, it's one of the toughest issues, I think, to address as a country, as a state, as a community. Within states, there are some communities and some large cities that are still in a state that may otherwise be a C. So it's a tough issue. It's not an easy issue. And it's a cross kind of issue that we're going to, have to address. Obviously, within Virginia, you will see areas that are doing well, and then areas that are not doing so well. But one thing is certain, that we know the risk factors, at least in terms of high risk for racial minorities, as well as the level of care that's needed. When you start to go and heal, but you see that prematurity and its complications are the leading contributors to infant deaths. In this chart, you can see, in the pie chart, if you put all the preterm related deaths together, it's actually the biggest contributor to that. So the second one actually is all other causes. Think about that, that's about a third, but more than a third almost is the prematurity. So it's a very critical and important part of the mission. And certainly we are having with our research centers and other work, working both on basic science research, but also some of the translational research. What can we do to actually get the research in operation out there? So there's a lot of exciting work going on at March Times and its partners. So we appreciate working with you as well on some of these issues. The maternal mortality, I'm going to try not to repeat a lot of what my other colleagues have also mentioned very eloquently already. We marched in October, did this blanket change. It received a lot of attention. The idea of blanket change was to talk to constituents all over the country. It was also to speak to policymakers, people who are running candidates for the 2018 election here, as well as our president, Stacey Stewart, provided congressional testimony and had several awareness events across the country. We also had a landmark national symposium with Morehouse School of Medicine. And the idea here again is to raise awareness about what's happening with over 700 women. That's 2 women a day that are dying. But again, as was mentioned, it's the near misses that's the bigger problem of 50,000 plus women. And then the disparity that exists within the category of maternal mortality. Part of the blanket of change, what we are still continuing to do is to address the lack of access to care that threatens the health of moms and babies across the country. We have, and I'll mention a little bit about this, the Maternity Care Desert Report in a minute. We want to obviously focus requiring all health plans to cover people with pre-existing conditions. You'll be surprised, if you join, I joined my class. But if you're a woman, and if you become pregnant and you decide not to have coverage at that point, for whatever reason, remember there's a law that has been struck down right now, and it's not been upheld yet, but there's a threat already there. The challenge will be, having a child by today is a life event for insurance purposes. Becoming pregnant is not. So this becomes a big issue with that. So we have to be careful about where things are moving and how the gains can easily be lost. Similarly, working on issues of, we don't have to trade maternal benefits to afford health coverage. That's an issue. So these are some of the screenshots. This is the blanket memorial on the National Mall. These blankets, 700 blankets were placed in the mall to represent and demonstrate. And we call the Maternity Care Desert Report. This report, for the first time, demonstrates about a third of the county, that's over 1,000 counties, encompassing about 5 million women of childbearing age live in maternity care deserts. That includes about 150,000 babies that are being born. So that's a problem. So we have an issue with, the disparity within race and ethnic disparity, the disparity between rural and geographic and urban areas. And we've got to figure out how to. I don't think we're going to have one size fits all solution to this. And we've got to work towards that. The future plans for climate change really is to actually work with state partners like you. Have this on the agenda. Have events that target local markets and talk about it. Talk about this a lot more. In 2018, we obviously had a lot of impressions. We see 16 million impressions, online conversations. So the level of discussion is being elevated, and we can't lose that progress that has already been made. It's very important in 2019 we continue to do that. Next, I just want to talk about, as I started with the opioid disorder and MAS. This slide really looks at the amount of prescriptions by state in 2016. And if you look at the dark maroon states, that's like more than 107 prescriptions per 100 men, women, children, infants in a year. So everybody got one and then some extra, right? So that's a problem. And the problem is, we give out about 226 million prescriptions for opioids in a given year, in a country of about 300 million. That's an issue. So as much as progress as we are making, the high level of prescribing is still a big problem. It's a big problem. And we've got to figure out how to address that. Particularly among women, about 1 in 3 women of reproductive age filled an opioid prescription between 2008 and 2012. Opioid use disorder, that we shouldn't be surprised, at delivery increased by more than 4-fold between 1999 and 2014. The passion we had as physicians, we as internists practicing, about getting everybody's pain treated down to 0. I wish we had the same passion to, fight maternal mortality, preterm births, addiction, substance use disorder. And that's the part of the problem we're going to have to look at is how do we actually move forward? We have to reduce the amount of prescriptions, but at the same time, it goes back to the social determinants I talked about. One thing we did in West Virginia was actually, we took every one of the, several hundred, there's a West Virginia dying every 8 hours because of opioid overdose. We took every person from the medical examiner's office, and we did a social autopsy of that person. So we just didn't look at the person's cause of death. Okay. We went back and we tracked their incarceration records, we tracked their work employment history, we went and looked at their medical records, their EMS records, their employment history, their marital history, everything you can imagine that we could get. And then we developed a composite of each individual. These were like 800 people. And what we found was compelling. We were able to then look at every one of those, develop that, turn that into data, a data-driven approach. We found only 2 out of 10 people actually got naloxone at the time of their death. We found that 90% of people had filled an opioid prescription, 50% of the women 30 days before their death. We found 56% people were incarcerated within 30 days of their death and released. We found that a third of people work in construction industry. Majority of the people were either not educated or not educated enough, and single. So these are the societal and social factors that are probably playing a lot of role in this area also. We saw some of that from our maternal mortality review teams, that it's a lot more deeper than that. And there's some other factors that we need to capture just then, rather than just the medical histories. NAS is another area. I think you get the rates what you put in as a definition. So the rates across the country is about 1%. So far the report rates, as you can see, in Virginia, The part to take away here is they're going up. We still don't have, very similar to maternal mortality, a consistent definition of NAS across the country, and then consistently putting that in birthing centers across the country. So that's a lot of work that has to be done. I show you this slide from the Department of Health. My colleague at Don Brezhner has done some of this work, and it really talks about the opportunities for intervention, both mom and the baby. This really starts preconception. We really talk about prevention of substance use. We need to talk about unintended pregnancy among risk women. And prenatally, identification as early as possible for maternal risk factors, and referring women who do have SUD into treatment early. They had a program called Drug-Free Moms and Babies, and what we found was when you consistently follow ACOG recommendations of screening and then refer people, women, and make sure we track those women, we found there's a tremendous rate of referral and treatment and stay in treatment. And at 2 years, it was like 70% when we were drug-free. Drug-free at delivery and drug-free at 2 years following that. Appropriate facility, I know there was a discussion this morning about levels of care, determining levels of care. I think it's important, it was, I want to say back in 1970, back in the report came out, that talked about the levels of care, and now only are we thinking about it. Indiana just passed legislation. I think it's critical. If we can't, and we used to think about it's only about the baby, but it's also about the mom, right? So we've got to think about how do we make sure that the high-risk moms and high-risk babies will be referred to the appropriate level of care. That's just the bottom line of that. Same thing at birth, the prompt diagnosis, evidence-based treatment. Again, I've seen a lot of non-adaptation of science-driven treatments for opioid use disorder, which is troubling in so many different ways. Stigma included of being a big one. And then social family support. And we'll talk about some of the programs from March Times regarding that. We still don't have a lot of science. We know some, the impact, the long term on the child of NAS. We don't have a lot of data on that. Part C, which is part of the IDEA grant, that's the Federal Intellectual Disabilities Education Act. Part B is, the education part that you're getting for children in schools. Part C is birth-to-free programs, and some programs like that, they usually house in health agency of the state. But that's the idea of referring early, diagnosing the referral to the child. Not wait till they go to kindergarten or school otherwise. And awareness and monitoring. And obviously the Part B referral of the idea and ongoing monitoring by providers. So those are three big buckets, right, for March Times: prematurity, maternal mortality, and NAS/opioids. But I think the cross-cutting issue that in so many ways we've talked about this morning, today, is actually equity. And it's critical to talk about it because if you look at preterm births, you can see that preterm birth rate among Black women is 49% higher than the rate among all of women. So that's a problem. It's just a pure problem. Now, that's in preterm birth. And here's in maternal death. Right? In Black women, that's 3 times higher and worse than other races. So you have to look at equity as not as a single box, but something that cuts across, something that informs everything we do. And that's where we have to make an impact. And when we talk about social determinants, equity cuts across everything. So outcomes for moms and babies are going to be impacted by personal health, issues like nutrition, access to healthy foods, the full spectrum of being healthy, pregnancy, preconception care, all the way to postpartum and the fourth trimester. To social environment. Education is important. Social stress, job opportunities, and really what we also want to focus on is work policy, families. And we're concerned about, we talked about the ACA part. What happens to moms and working moms if the ACA gets shut down? We're really concerned about that. So So those are the kind of things that are important. Healthcare system is also important. Access to care, hospital provider policy, that was plenty discussed today, that's so critical, and insurance status. One of the things we also found in Medicaid expansion is, it's just having expansion doesn't mean people are going to come. So now, in Virginia, we're reimbursing people for travel, the mileage and everything else. So you're going to have to continue to push the envelope upstream until we get people to get the help that they need. Behavioral, obviously we talk about addictions, and a pill isn't going to solve the problem. And the built environment, I think it's critical to think about Medicaid plans across the country, and certainly private health sector insurance companies are thinking about that you wouldn't have thought about 10 years ago. They're thinking about housing, they're thinking about neighborhood safety. Can someone get a child care so they can go to work and don't have to worry about that's where their check goes for the week? So these are all important and complex but important issues when it comes to the care of moms.